healthcare discrimination is one reason for needless amputations. Another reason is also misdiagnosis and unfortunately no diagnosis until it reaches, or peripheral artery disease reaches, advanced stages. Some patients have actually told me they were never officially diagnosed with P.A.D until after their first toe amputations. Doctors just brush it off as old age, or when it comes to diabetics, neuropathy. And they offer pain pills as the quick fix. But what's really necessary is a long-term solution. So I want to discuss now the truth about neuropathy and how to know if it's P.A.D or if it's something else.
I think when it comes down to it, it's not something that is very easy for us to tease out. And I don't think it's easy for the patients to tease out. The symptoms may overlap when we're talking about neuropathy versus peripheral arterial disease. Mm-hmm. And then really be blended. You can have patients that have a component of neuropathy and a component of P.A.D. So it starts essentially, in an office visit, either with your primary care physician, your podiatrist, an endocrinologist, even a vascular interventionalist, vascular interventional radiology, or vascular surgeon. What we start with is essentially asking the patient key questions about their pain, trying to get a sense of when they experience pain, what are things that relieve the pain, what are things that exacerbate the pain, duration, location. Those are some of the key factors that we look for. But ultimately, the next step is going to be some type of diagnostic study. Unfortunately, our diagnostic studies aren't very good right now, to be frank, about diagnosing and teasing out neuropathy. Absolutely. We still struggle with being able to tease out the difference between a patient with ischemic neuropathy or diabetic neuropathy. We struggle with that.
Can you talk about the differences between those two?
So diabetic neuropathy would be a patient who oftentimes has diabetes, and their pain is going to be a burning or numbness or a tingling type sensation. Ischemic neuropathy, often classified consistent more with breast pain or critical limb ischemia, can cause not only pain, burning, but also those ulcers that we can see in some patients. So there is another component that is associated with the pain and neuropathy that patients are experiencing.
What tests can you actually use to confirm? Is it possible to really confirm in a non-invasive way?
I think that's up for debate. I think the classification of neuropathy, it's an assessment. It's a collection of clinical manifestations. There isn't any test that I know of that can diagnose or determine whether it's diabetic neuropathy versus ischemic neuropathy.
It's really just getting to the point. And Dr. Leschak, you can feel free to weigh in here as well. If you want to test at least to see if it's a circulation problem, you could go, some doctors will, go to an ABI test, ankle brachial index, where they put blood pressure cuffs on your legs and your arms, and they measure the differential. But with patients who are diabetic, it could get a false normal. So the real test is an ultrasound.
The ultrasound will tell you if there's any disease in the artery specifically, stenosis or an occlusion. You still can have a normal ABI with a posterior tibial occlusion, one of the vessels going down the leg that's higher up than the ankle. And the TBI or ABI could be normal. With the neuropathy and the pain and that kind of ischemic pain, what I see is patients have inframalleolar disease below the ankle that won't be detected on ultrasound necessarily. So they'll have disease in that one artery and the loop, the plantar loop. And that, if you fix that, a good chance you can relieve a lot of their symptoms of rest pain, some of their neuropathy. But you may not necessarily pick that up on the ultrasound or the TBI. It's very difficult. I struggle with this because we do have a lot of patients come in with normal ABIs, normal TBIs, but when they're saying to me, I have severe nighttime cramps, nocturnal cramps, which is a form of rest pain, and they have neuropathy, but they really have normal studies. Unless you do a really dedicated ultrasound, you may not pick up some of the more subtle findings, proximal subtle findings, such as the narrowing, things like that. So I use the ultrasound as a guide, but it's not the end all be all. So it's difficult. It's a difficult study in these patients to really act on.
how would you determine, along with your patient, that now's the time to do what's called an intervention, where you make that little keyhole incision and you go in with wires and
Right.
balloons and things like that to restore some flow in areas that might be blocked? And what questions should a patient ask their doctor to help them make that determination if now's the time and if that's the right course of treatment?
Well, I can tell you some of the patients that I've seen with diabetic ulcers, the classic diabetic on the underside, the plantar surface of the foot, have normal ultrasounds. Okay, so I've seen that. And those patients have inframalleolar disease below the ankle. If you have an ulcer, there's a pretty good chance you have some vascular component to that, high likelihood in a diabetic. So those patients, I will, no matter what the ultrasound shows, I will take those patients to angiography and at least look. And in most cases, I will treat those patients. There's something there going on. And if you fix that, you have a better likelihood of healing that ulcer. And that's my experience. I'm not sure with Wande, you agree with that sort of assessment?
Yeah, I think it is a judgment that the interventionist has to make, and the components that go into it begin with the patient. If the patient has symptoms that warrant some type of intervention, I agree with Steve. You have to go the next step, whether that's a diagnostic angiogram with a possible intervention, particularly because the ultrasound is going to be unreliable in those patients. But if the patient has no symptoms, I think being aggressive with a diagnostic study, even if the ultrasound is normal, you have to be very careful in those patients as well. I think, again, it's a judgment call. I think the interventionalist as well as the patient have to make that decision.